you everyone for joining us today. I'm going to do a bit of commentary to set the stage and introduce our two speakers, Molly and Mark. And then we'll have some Q&A and conversation, and feel free to use the chat bar to submit your questions. We hope you'll have some, and we're looking forward to engaging in a lively conversation. In the chat bar, Linda has also placed some supporting materials for this session. There is a case study on Stop the Spread Hyperlocal response, and also some information on the pandemic response network that Mark will be talking about. So please avail yourselves of those materials. So my name is Sharon Knight, and I am the Executive Director of Stop the Spread, a COVID-19 response nonprofit that was created in March to catalyze the private sector's response to the pandemic. After an op-ed piece in the New York Times created a call to action, we had over 1,300 CEOs and executives sign a petition to stop the spread, and that really galvanized our organization. In June, Stop the Spread merged with ImpactAssets. ImpactAssets, which many of you probably know, is a leading facilitator of direct investing through donor-advised funds. And they had created a family of COVID response funds, including a Stop the Spread fund early in the pandemic to address immediate and evolving needs. So it was a great marriage between our two organizations when we came together in June. Together, we've been successfully facilitating partnerships and funding to address critical needs for tests and therapeutics and PPE, and to provide financial support to individuals and small businesses. I don't think anyone would have thought, back in March that our work would still be needed. I think people thought we might need to be around for 6 months max, but here we are, 8 months into the pandemic. Yesterday, we reached more than 8.3 million cases in the United States and over 222,000 deaths. And just yesterday, more than 60,000 cases were reported across the country. This is the highest level that we've experienced since July. And many experts think that this may be the most challenging and dangerous peak yet, as we are coming upon winter and the holidays, and people have enormous pandemic fatigue. The COVID-19 pandemic has disproportionately impacted communities of color throughout the United States. Racial and ethnic disparities in healthcare are known factors contributing to both higher morbidity and higher mortality rates among people of color as compared to white Americans. These disparities have a dual impact. Not only are they resulting in differences in actual care and treatment for COVID-19 that patients receive, but they also put people in BIPOC communities at higher risk of contracting COVID-19 in the first place. So today, we're going to discuss how hyperlocal strategies can address COVID needs in underserved communities, and explore how impact investors and philanthropists can play a critical role in this phase of the COVID pandemic response. So joining me in conversation today are Molly Chidester and Mark Sendak. Before sharing their bios, I'd like to acknowledge that none of us are experts on what specifically a majority Latinx, immigrant, Black, or Native community needs, and we aren't going to pretend to be, but we are working with and through community organizations to address critical needs in the country's most vulnerable communities. So really pleased to have with us today Molly Chidester. Molly actually joined the Stop the Spread team in September as an advisor. She joins us from New York City Health and Hospitals, which is the largest public healthcare system in the country, serving over 1 million New Yorkers every year in largely underserved and vulnerable communities. At H&H, as it's known, Molly served as Chief Strategy Officer for the system's performing provider system, which is called One City Health. And they were charged with bringing healthcare providers and payers and community partners all together to transform care for Medicaid patients under CMS in New York State. In June, May or June, Molly, you joined the New York City Test and Trace Corps, supporting communications in community education and awareness that are so important, as well as contact tracing for healthcare workers. So thank you for being with us on the panel today. Dr. Mark Sendak is the population health and data science lead for Duke Health for Innovation, where he leads interdisciplinary teams to build technologies that solve real-world critical problems. Mark and his team have built and integrated numerous machine learning technologies into clinical care, including population health tools and sepsis detection and management platform. In late March, Mark and his team at Duke launched the Pandemic Response Network. This network leverages capabilities and expertise from across Duke Health to empower individuals and communities to identify medical and social COVID-19 related needs and rapidly connect those people with the services that they need. With a focus on supporting historically marginalized communities, the program has over 7,000 participants from over 40 states across the United States. It's the only program in the country that provides telephone follow-up for everyone, anyone, anywhere who have severe symptoms, and it's the only program in its kind that's in the country that's available in Spanish. After months of meeting with more than 1,000 community members and organizations across the US, PRN is refining its approach so they can collaborate directly with communities to co-design and launch community-led implementations of their program, which is called Community Health Watch. These partnerships involve public schools, health clinics, and religious organizations. Step the Spread has been really inspired by the work of Mark and his colleagues. We've been a partner to the organization for many months now. And we've been so inspired by the work that they're doing that we have adopted some of the practices in our own evolution of our work. Today, we're going to engage Mark and Molly in a conversation that I hope you all will find informative and engaging. We're looking forward to your questions. We want to talk about the needs of underserved communities and how those can be best addressed. So once again, please use the boost chat function if you'd like to engage with either Mark or Molly or both, all right? Okay, to begin. So what's interesting, Mark and Molly, both of you have had very unique vantage points to the pandemic. Molly in New York City and Mark in North Carolina, two very different geographies. I'd love it if both of you would share with our audience what you've observed to be the challenges of combating COVID-19 in underserved communities, and give us a little color of what that's like on the front line. Molly, why don't you talk about New York first, and then Mark, add on with what you've experienced in North Carolina.
Sure, great. Well, thanks, Sharon, Mark. Nice to see you again. And Sharon, thanks for the introduction. I think this is a really important conversation to be having in any discussion around the pandemic. So I'm looking forward to it. I thought I would start by just sharing a little bit with the participants about New York City Health and Hospitals and who we serve for those who aren't familiar. So as Sharon mentioned, H&H is the largest public system in the United States. That means we are the safety net provider for all New Yorkers. So we see patients regardless of their immigration status, regardless of their gender identity, regardless of their ability to pay for care. We serve about 1 million New Yorkers a year. We're spread across the 5 boroughs, and we have, just to give you a sense of size of the system, we have 11 hospitals, 5 level 1 trauma centers, over 70 community clinics. We provide 60% of New York City's behavioral health services, and we also provide correctional health services for the city's prisons. And when you look at the patients that we're serving, I just wanted to share a little bit about what the community looks like. Up to 50% of patients in any one of our facilities will speak a language other than English in their home. They are predominantly Medicaid or uninsured patients. Many of them are uninsurable, unfortunately, because of their immigration status. They are majority non-white, mostly Hispanic and Black, and they make up a lot of our essential workers, which is really important during COVID. So they are the front lines of factories, grocery stores, keeping the city running through taxis and Uber, and the public transportation system. There are many of our healthcare workers. And unfortunately, when COVID hit in New York, so to your question, Sharon, a little bit about just sort of observations, many of these individuals that we're serving, they don't have a primary care provider that they are getting information from about the pandemic, or that they can speak to when they have symptoms. So a lot of them were showing up in our emergency departments. Information was changing really rapidly. We had to communicate a lot of information in a lot of different languages. We had to talk to patients about their symptoms. We had to have some really hard end-of-life conversations that were unexpected with people who are non-native English speakers. And many individuals, didn't have the option to stay home or to work remotely. So they were continuing to go to work and be exposed to the virus. And a lot of these individuals and communities are living in multi-generational homes. So they needed places if they were to get sick where they could safely isolate from their family and loved ones. And just wanted to share that to understand some of the challenges that individuals were dealing with. I would also say that these are the most vibrant communities in New York. They're the strong communities in New York. They are the communities that make New York, frankly. But unfortunately, when COVID hit, they had to deal with some of the structural inequity that was already in place that put them at a disadvantage to be able to fight the virus. And I think COVID has exposed that inequity. I think it's exacerbated that inequity. I know we're going to talk a lot about that today. Before I pass it over to Mark to hear a little bit about North Carolina, I did just want to share, this is a statistic that I think is really profound. Some of you may remember Don Berwick. He was the former head of CMS under the Obama administration. And he talks about how life expectancy in the United States is often best predicted by your zip code, best predicted by where you're born. And I think, unfortunately, that's been a lot of what we've seen play out in COVID as well. So if you were to take the New York subway and go up the east side of Manhattan, you get to the Upper East Side, very affluent. You go 6 minutes north on that subway, and your life expectancy just decreases by 9 years when you get to East Harlem. And I think that speaks to how the community that you're living in and experiencing the pandemic as well really determines what your story is during this time, unfortunately. I think, Mark's team and New York City H&H are doing a lot to combat that. But that's probably my biggest observation. And so when we look at New York, which was the epicenter very early on, it wasn't Manhattan necessarily that was the epicenter of the pandemic. It was Queens. And within Queens, it was Elmhurst, it was Jackson Heights, it was the area called Corona. These were the neighborhoods that were truly the epicenter of the pandemic in New York. And Mark, I don't know if that is similar in North Carolina. We've talked a little bit about similarities and differences in the past, but I'm curious your perspective.
Thank you, Molly.
So, Durham is definitely a microcosm of anything from New York. So to me, some important differences. So Duke University does own and manage every hospital bed in Durham City and County. It's a 3-hospital health system with about 80 to 100 outpatient clinics. So we also have about 1 million patient encounters per year. I would say that in mission, we are the safety net provider, but we also are a large academic medical center. And much of our care is more oriented towards the high margin, high cost healthcare that people come to Duke for. And we have lots of inter-hospital transfers for very complex conditions. So in some ways, it also surfaced the same gaps that you mentioned, Molly, which in Durham were large for our Latinx and African American communities. Something that for me personally was very vivid. I was actually born in Southern California, and I lived in LA for 5 years before moving to Durham a decade ago. And in California, the prominence and the establishment within Latin American communities is much more formally integrated into public institutions, whereas in Durham, in North Carolina more broadly, it's a lot more first-generation undocumented immigrants who are, many of them, migrant workers. And so a much bigger gap in terms of language accessibility, translation services. And there was a period of time where up to 90% of our new infections were within the Latinx community, even though they make up 13% of our population. So huge disparities. Some other interesting points working in the South is the strong network of faith-based organizations. We've worked a lot with United Methodist churches, which actually cut across ethnic and racial subgroups in our region. And then another important fact is North Carolina being a purple state, there's a precedent and openness to deploy public resources outside of public institutions. So in terms of building capacity, laying infrastructure, there's definitely an openness to deploying these resources quickly and rapidly outside of public health and the public infrastructure, which in some ways did allow us to move really quickly, but also presents problems and challenges when you think about sustainability and what we do long-term in terms of community health.
Well, thank you both for sharing those challenges or similarities and clearly some differences. It makes me all the more appreciative for how hard our healthcare workers have been working to provide not just physical care, but social and emotional support as well. So I'm curious what you both think a sufficient response looks like given these challenges. Molly, you spent time in the New York City Test and Trace COVID response unit. How did H&H take on New York City? What kinds of solutions were important to being on the? I mean, we all saw the news. We saw the photos from the hospitals. I mean, obviously New York got through that, and hopefully there's not going to be another surge with what's going on in Brooklyn, let's say. But what is the response? What does good look like?
Yeah, well, I'm glad you're asking that. I think part of that response, of course, is having sufficient testing and screening in place, the ability to communicate around the importance of hand washing and wearing masks. But I think the pieces that aren't talked about enough, and part of what New York City tried to address in their test and trace core, was making sure people were really connected to both physical and mental health care services and addressing basic needs that are really important to a COVID response. So the city's test and trace core, had three different arms to it. One was test, one was trace, and the third one was take care. And I think that's really important. And I would say even looking at testing, testing wasn't just testing in New York. It isn't just testing in New York. When we deployed a rapid point of care test, which is where you can wait 15 minutes and then get your test results, we use that 15 minutes to sit down with people and have a conversation about what other type of help they might need. Are you getting enough food? If you were to test positive, would you need food delivered? Would you need your medication delivered? Are you experiencing any kind of violence in your home? Can we connect you to resources that are going to help you get through the pandemic? We did the same thing with contact tracing. So when someone was picking up the phone and doing a case investigation, they're also potentially bringing in a resource navigator to help make sure people are getting the support that they need. And we did all of that work, and Mark can speak more to what PRN has done here, but we did all of that work with the community, which I think is really important. These were place-based operations. We're setting up testing in churches and schools and community centers, places people already go. We were working with community-based organizations to make sure people would answer the phone when they got a call from a contact tracer. And we were, if people weren't answering the phone, even if we had a centralized contact tracing system, we still needed to be able to go out door to door and connect with people, let them know they might be exposed, let them know they need to test. Doing that is really hard. It takes establishing a lot of trust with the individuals that you're going out and talking to. And so our contact tracers in New York, 50% of them were from the communities where we were doing the contact tracing. We were translating materials not just into Spanish, but into Urdu, Yiddish, Bengali, Haitian Creole. I mean, really getting very local to communicate with people. The other thing that I think is really important around contact tracing is making sure that those contact tracers have the right kind of training to really address the community in a way that makes them feel safe, makes them feel like there's trust and they want to share their information. So, we did health equity training, we did implicit bias training. We did trauma-informed care training to make sure that those case investigations were going to be successful. So I think even if you're doing this work through a sort of tested citywide, in an 8 million population city, citywide test and trace effort, we still had to have local strategies to really reach these communities.
Yeah, that's a great point. I mean, Mark, you stood up Pandemic Response Network. Right? You've been working for over 6 years at Duke Health to build technology and workflows and systems to address challenges that the community is experiencing. My understanding is PRN was all about helping people stay safe and connected during the pandemic. How has your approach been similar or different to what H&H deployed in New York?
I mean, I think it's a really great point to compare and contrast, because I feel like we had to quickly enter communities and meet communities where they were in ways that we may not have beforehand. Whereas H&H is formally part of the public health infrastructure for New York City, Duke Health doesn't have that same type of relationship and role in the local community or at the state level. So one important thing for me that I kept in mind throughout my time doing this work is, in many ways, it's the same job I've had the last 6 years. The last 6 years, we would work on a portfolio of innovation, human-centered design, rapid iteration, design, implement, evaluate technologies. If they're successful, operationalize them. The biggest difference was that the last 6 years, I mostly work with physicians. I work with nurses, physical therapists within the healthcare setting. The reality that we've learned very quickly with COVID is that the root cause problems are not in healthcare. They're in communities. They're in these marginalized communities. It's around barriers to access. So my role has become much more outward facing. Now I spend time with undocumented community organizers, with church pastors, with folks who need to work with their children, who are trained as community health workers, having their children help them use the technologies that we've deployed in the communities to help them do their case management. So it's a very different set of users, which I feel like really now it's about how do we take these processes and the infrastructure and capabilities we have in these formal institutions and rapidly deploy them to empower the support that we've seen emerge from these communities. So to me, it's been absolutely thrilling. And we're working with K through 12 schools. I was mentioning right before we started this session that we finally had a proposal today approved by our local mayor, city council, to support small business workers in food services. We're also working with construction companies. So it's, how do we bring together the health and social services, do that community level monitoring, and if we identify a need, rapidly connect the person to resources. And similar to Molly's point, I would say one difference is that rather than bring together contact tracing and that community level support into one role, we do still have them as separate roles. So in North Carolina, contact tracing is still largely done within local health departments, and those are staff that are onboarded and supervised within health departments. But the state HHS has also funded community health workers to be housed in churches and community-based organizations. So our boots on the ground are much more the community health workers, and we call it filling the gaps around contact tracing. So how do we provide those ancillary services and more longitudinal support for these individuals affected by COVID?
Great. Thank you for that. I do see a couple questions coming in from the audience. I just want to acknowledge that I see them, and I will weave them into our conversation shortly. I thought it might be helpful, the title of this session today refers to hyperlocal, and what I think Molly and Mark are both talking about is a hyperlocal response to the pandemic and to society's challenges. And I thought it might be helpful to just align on a definition of hyperlocal and what it means to me and how Stop the Spread is thinking about it. We're thinking of hyperlocal as a structure being structured around a very well-defined or targeted community, with the primary focus being on very specific needs and concerns of that population. So not coming in with a one-size-fits-all approach, but in getting involved and embedded in the community to understand their needs and then address those gaps and listen and learn and respond. So on one hand, though, it seems to me that why should we or others, you all need to do this work? Shouldn't the public sector, be doing this? Why is there such a gap? Where does the public sector's responsibility begin and end in this equation? And where do others need to pick up? Molly, what?
I'll go first. Mark, jump in too. So I think they play a critical role in mobilizing resources, in raising awareness, in setting policy and regulation. I think you said it, Sharon. There's really no one size fits all way to do this, and I honestly don't think anyone can do it on their own. I think that this is going to take, and I see the question about vaccines too, which I think we'll talk about, but especially in, when we think about vaccine dissemination, this sort of unprecedented ability to collaborate between the public sector and the community. I think community-based organizations have to be at the table in those conversations. They know what their community needs. They often don't have the resources that they might need to fill those critical needs. And on the flip side, the government is able to do a lot to build centralized and scaled response, but it is hard to tailor that to a community without understanding the specific environment that those community members are living in. I think that's where, at Stop the Spread, we see a really big opportunity for philanthropy and impact investors to help address some of that disconnect or that gap. I think, philanthropists are passionate about these issues. They are passionate about investing in communities that have historically been underinvested in, and they can bring funding to the table. So whether that's program infrastructure to facilitate trust between new partnerships and to create a platform for collaboration, or whether that's bringing new services that can augment what's happening locally, there's a really big opportunity for them to be players in this work to bolster and accelerate what's happening locally.
Great. Mark, do you think communities can do this on their own, or do they need outside actors involved as well to be successful?
So I have been absolutely in awe of the communities that we've been able to work with. So I'll give one example. There's a local church in Durham called La Semilla, and part of La Semilla is this very active group of essentially community organizers who for a long time have been doing what's called deportation defense. So as I mentioned, in North Carolina, there's a lot of first-generation immigrants, many undocumented workers working in construction, working in agriculture. And these are the first lines of defense for families that are scared when they get phone calls from a public agency or there's any type of interaction with the police. So what we found is by empowering these individuals and these kind of previously underground networks and empowering them with public resources. So when you talk about should the public sector be doing this, almost all of the funding we've received that we've brought into these communities to hire these community health workers is through CARES Act. It is through our state HHS agency. We were awarded with our partners a $5 million grant to hire these community health workers. But it's short term. This ends December 31st. So giving that type of capacity in these communities, because these folks, they're working other jobs, but dedicating time to provide that type of community level support, help connect people to health services, to social services. When we talk about something like vaccines, it's not going to be me telling somebody that a vaccine is valuable that will convince folks in communities that have largely been neglected by health systems. It's going to be these types of community organizers who we're now working closely with side by side to bridge these gaps. So, and I can share some links. Univision did an entire 15-minute video about these communities that we're working with in North Carolina. So there is a lot that the communities can do. And I would not underestimate what's already happening in your own backyard, wherever you are, because there are communities coming together to respond, but they do need resources. They need support. They need expertise. They need a seat at the table. I can't tell you, probably every day I forward 10 to 15 emails that I get about different grant programs, about updates to different public health guidelines. And I'm just trying to keep these communities informed, because we have a lot of power wherever we are situated, that we need to be able to create those mechanisms of access to resources and expertise.
That's great. Thank you for that perspective. I'd like to turn back, since this is SoCal, turn a little bit back to talking a little bit more about philanthropy and impact investors, and specifically about Stop the Spread. And Molly, I'd love for you to share with the audience why Stop the Spread is turning its attention to this kind of hyperlocal program.
Yeah, I think so. Stop the Spread, and before I came on, was doing amazing work in building capacity for diagnostics, therapeutics, the ability to disseminate PPE. I think the team has seen that there has been across the U.S. an inequitable distribution of these types of resources, and we recognize, and again, part of this was inspired by the work that Mark was doing, and the experience I had in New York. The best way to get these resources into the communities that are hit the hardest is really going to be through a hyper-local and community-led approach. So we have been building this robust network of resources. We're sort of calling this a toolkit, and we're starting to go beyond pure COVID response into some of those other areas I was talking about earlier. Digital health, the ability to connect people to other sorts of needs like food or potentially legal services if they're having trouble paying their rent. And so I think that's primarily why we want to get into this space. Mark has worked with STS, so can speak more about our potential to do that and what his experience has been. But yeah, that's what I would say, Sharon.
That's great. I'm going to present a question from the audience to Mark, since Mark's a physician. We have a question around testing, and Eric asked this question yesterday in our session about testing, although we obviously didn't answer it sufficiently for him, so he's asking it again. So I want to share it with testing and actually combine it with a question that Amy has as well around vaccines. So thinking about vaccines and testing with a hyperlocal strategy. I'm going to share Eric's question first. So we released some data last week in partnership with others on lab and hospital testing capacity nationwide. Unfortunately, we see that labs and hospitals are only testing at 41% of max capacity. How do we bridge this gap? And then Amy wanted to know if a hyperlocal approach would facilitate vaccine distribution when the time comes. So I think I know what your answer will be, but I'd like to turn it over to you and say, how can these gaps be filled by hyperlocal?
So I have spent an inordinate amount of time the last week and a half figuring out how to bridge Duke's lab testing capacity to the local business community. So folks may not realize that Duke University has been missing from the news, which from our perspective is a great thing. So we have not had an outbreak. We do 10,000 to 15,000 tests a week. We do surveillance testing for our university campus. I will say we do not do this for health workers. So we do not think that a return to work actually requires surveillance testing. So our health worker programs, we've had 20 to 30,000 healthcare workers showing up to work every day since the beginning of the pandemic. But we have dramatically increased our lab testing capabilities with the reopening of our campus, originally in July for athletes and then August for students. So what I'm doing right now with the team at Duke and with our local city government, with the mayor, our city council, is streamlining access to testing for business employees who are either exposed or symptomatic. And we're focusing on business environments where there is crowding in the nature of work. So the two use cases right now are largely restaurants and construction. So it's, to Eric's point, we have capacity. I've also learned recently that there is substantial federal funding even for folks who are uninsured. So we originally were figuring out how to fund these tests in these employment environments where most folks are uninsured, but our default will be sending all bills for these individuals to HRSA for reimbursement. So there is federal funding for COVID tests. And it is a question both about having the lab capacity as well as streamlining the access points. So anyone in Durham can call the Duke COVID hotline. But now I'll put on my hat as someone who builds clinical decision support. So it's not just about having access, it's about having the right information to the right person at the right time. That's why we're building all of this into our app that we're deploying in Durham. We're calling it Greenlight Durham. So at any point, as part of the daily check-ins that employees will do before they go onto the work site, if they have symptoms, if they have an exposure, we give them the instructions right there. They can hit a button, call the COVID hotline. We navigate them through the phone tree. If they're symptomatic, they have to get a virtual visit. If not, they can get straight scheduled for the test. These are drive-through testing sites. So it takes work. And I mean, this is a month in the making of trying to take our lab capacity to the community, but find the right entry points about where are people most effective. And I'll tell you, even within the last 24 hours, there's 3 restaurants that I've been helping get people tests. I'm hoping I can get paid in sushi because it's actually one of them is the best sushi restaurant in town. It's gotten me fired up about being able to do hyperlocal because there's the businesses that we want to thrive through this. There's the economy. I mean, there's huge implications.
Yeah, no, I mean, the capacity is there. It's matching the supply with the demand, as you said, the right resources in the right format at the right time to connect with people.
Yeah, because people are inundated. I mean, the state of North Carolina has its own hotline. Each county has its own hotline. The public health department has their own hotline. So it's really confusing for a business owner to know, where do I call? If there's a positive case and 6 people were working the same shift, how do I get those 6 folks tested?
When you provide the information about testing, though, if you're providing these to undocumented immigrants or people who are working in hourly jobs who don't have access to sick pay, do they say, hey, thanks, but no thanks, because if I get tested and I'm positive, I'm going to have to stay home, and who's going to, pay my rent and feed my family? And is that a challenge as well in terms of generating sufficient demand?
So the way that I view this is resources just like fell down from the state, from the government. So like there's a set of resources for social service reimbursements. There's a set of resources for COVID relief payments. There's these community health workers. There's small business loans, but they're not coordinated. What you have to do on the ground is actually coordinate them and develop tools that put this at people's fingertips. So our state has funded COVID relief payments. Our state has funded CHWs, community health workers. We have now, our city is funding any gaps in testing access and the daily monitoring system. So it's tough because a lot of this is out there. You have to dig through the paperwork and what's been funded in what counties. But once you get through that, and it takes people time, you can actually coordinate these things. And this is where it takes partnerships and a lot of figuring out who's providing the different services, because the services are provided on the ground. But I do want to highlight a group like STS understanding the landscape, because certain services are not provided on the ground. You may need different types of technologies. You may need different types of resources that don't exist. So being able to pull those down to that hyperlocal level is also essential.
Great. I'm going to turn to a question that Alex Todd suggested a few minutes ago. Alex asks, what kinds of engagement in behavior modification mechanisms or technologies have been effective in helping stop the spread and relieve anxieties of social bubble members? He says, I have found that existing text messaging or mobile app-based systems are not very effective since they don't demand any level of commitment and also don't include carrots or sticks associated with engaging diligently. Also, they don't measure behavior change. Do you have a point of view? You've developed a lot of these technologies, Mark, on one-way versus two-way and fostering accountability and response.
It's hard for me. I don't think the communities that we are interacting with, such a thing as a social bubble exists. And it's hard to, Sharon, you brought up, for a lot of folks, it's a question of, do I keep food on the table? Do I keep putting myself at risk because of some good that I think I need to be able to do to provide for my family? So the behavior change, I've built a lot of technologies with our team, and many of them are very sophisticated, but there is no AI, there's no ML, there's no sophisticated data engineering in our work right now. It's really that core of how do we coordinate the services that people need to be able to make the decisions that are healthy. Like, you have to just think about, how do I remove barriers to make the right choice, the easy choice? And how do we make the right choice to stay home when you're feeling symptomatic or have been exposed? And that's not about behavior, it's about basic needs. And I mean, Molly, you've talked about this too.
Yeah, I mean, I totally I agree with you. And I do think, there is an opportunity for behavioral science to play a role in the language we use. I think being culturally responsive is super important to motivating people, to getting them out to test. But I think it is not out of a lack of desire or wanting to protect yourself from COVID. It is, in Maslow's hierarchy of needs, if you are between going to a food pantry, going to work, and getting a COVID test, you're not going to get a COVID test. And so that's, going back to the conversation earlier, I think that's why working with communities, taking a very hyperlocal approach is the way that we're going to get resources into the hands of people who want them and need them, but need to feel like it's safe to use them and to engage.
Yeah, that's great. I mean, if you think of, gosh, if everyone spoke English, everyone were educated, everyone had a salaried job that provided, sick leave and had health insurance, and had technology and Wi-Fi and had access, this would still be a challenging pandemic. But for the communities that we're working to serve, all those things are not the reality. So it makes it doubly challenging. Molly, I'd love it if you would share with the group, I see we have a few minutes left, where Stop the Spread is in our approach to hyperlocal. How are we taking this on? What's next? And then Mark, I'd love for you to weigh in on kind of what big piece of advice would you have for us as we embark on our first efforts here?
Yeah, so I think, so where we are now, we've built a great network of partners in the diagnostic and therapeutic and PPE space. Like I was saying earlier, we have been spending the last couple of months building out our partners in the health services space, as well as addressing some of those non-clinical needs that we've been talking about. So we're sort of establishing that toolkit. And trying to now understand which communities it makes the most sense to get started with. I think, our approach is very much going to be one of working with and through the community. So some of this will be the communities that are really receptive to bringing resources in. That's going to be really important to us. We want to bring an element of program infrastructure into place, like I was talking about earlier, so that we can not only create that platform for collaboration, but also do continuous improvement around the model, learn from it, capture best practices, so that I see Linda's question, can this be used in other pandemic disaster preparedness? We hope there are lessons that we can learn and that parts of this model can be replicated, even though you know, it may not look the same for other types of disasters or emergency. So we're now very much in the stage of trying to identify the communities where we can get started in effectively a pilot demonstration project.
Great. Mark, what advice do you have?
I think I echo a lot of the same messages of working very closely with communities and building capacity within communities. I know that I've talked with Molly about this before, but how do we take this opportunity of this crisis to show what effective investment in community health can look like and build more durable infrastructure that can respond to the next pandemic, to the next disaster, and empower these communities with the resources, expertise, and access to information and the types of resources that they'll need to be able to continue to do this work.
Great. Well, I'd like to thank both of our panelists today, Molly and Mark. Thanks for joining us. As for the audience, we'll be delighted to hear from community-based and faith-based organizations that would be interested in partnering with us. If we have a need or a gap, you have a gap that we can fill, we'd love to work with you to do that. We also are interested in talking to funders who might like to sponsor a program in their community. And then always, our toolkit is robust, but it is far from complete, and there are novel solutions being developed every day. And we like to say that Stop the Spread exists to unblock the innovators. So if you are a social entrepreneur with a novel solution pointed at the pandemic, please get in touch with us. We'd love to do more to extend our impact. So thank you for joining us today. Enjoy the rest of the conference. And if you have additional questions or you'd like to engage with us about programming, you can email engagement@impactassets.org, and we'd love to hear from you. Thank you so much, everyone.